My name is Nicole Smith. I'm a maternal fetal medicine physician at Brigham and Women's Hospital. And for the next 30 minutes, we will be talking about preeclampsia and eclampsia. I have no disclosures. So we will spend a little bit of time talking about the preeclampsia diagnosis, how we manage preeclampsia on a day-to-day basis, preeclampsia prevention, and postnatal counseling. I always like to start with a case. This is a pretty classic presentation. This is CM. She's a 32-year-old prima gravida. She initiated her prenatal care at 16 weeks with normal blood pressure, no proteinuria. She had a pretty straightforward pregnancy up until 36 weeks when she presented with an 11-pound weight gain over the last month. Her blood pressure was 160/115. She was edematous, and she had proteinuria. The only thing that stands out about this case is that actually this is from the case records of the Boston Lying-In Hospital from 1862. And, it's classic because because preeclampsia is a pretty classic disease in pregnancy. And the diagnostic criteria hasn't changed too much, although there have been some subtle tweaks over the last decade. In 2013, the American College of OBGYN released new guidelines for the diagnosis of preeclampsia. If you went to medical school before that, you probably remember mild preeclampsia and severe preeclampsia. So we don't have that anymore. We have preeclampsia with and without severe features. So for your basic diagnosis of preeclampsia, you need to at least have hypertension, systolic of 140 or diastolic of greater than 90 on at least 2 occasions, at least 4 hours apart. And ideally, you have proteinuria as well, which can now be not only just greater than 300 milligrams in a 24-hour specimen, but also protein to creatinine ratio greater than 0.3 or a dipstick reading of 1+ or higher. Now, preeclampsia with severe features can be identified either by higher blood pressures, so systolic greater than 160, diastolic greater than 110, or by evidence of end organ damage. So that could be blood findings like thrombocytopenia with a platelet count under 100, renal insufficiency with creatinine more than 1.1 or doubling baseline creatinine, or elevated liver function tests at twice normal. Certainly pulmonary edema or neurologic and visual symptoms will quickly get you a diagnosis of preeclampsia with severe features. We have a broad spectrum of hypertensive disorders of pregnancy, not limited to preeclampsia, which can make the diagnosis a little bit challenging. We've got chronic hypertension, preeclampsia with and without severe features, superimposed preeclampsia, which means that you have preeclampsia on top of your chronic hypertension, gestational hypertension, which is hypertension alone at the end of pregnancy, eclampsia, and then, of course, the HELP syndrome, hemolysis, elevated liver function tests, and low platelets. Preeclampsia, by definition, needs to present after 20 weeks gestation or around 20 weeks gestation, typically with hypertension and proteinuria or evidence of end organ dysfunction with hypertension. Some additional changes that have come with the 2013 guidelines is that proteinuria was removed as an essential criterion for the preeclampsia diagnosis because, of course, you can have a seizure or HELP syndrome in the absence of any proteinuria. Fetal growth restriction and massive proteinuria were removed from the list of features of severe disease. How common is it? Well, nearly 5% of pregnancies around the world are impacted by preeclampsia. A little bit less in the United States, although a higher frequency in first-time mothers. Few cases of preeclampsia, 0.3%, occur under 34 weeks gestation, whereas above 34 weeks gestation, 2.7% of pregnancies will be complicated by preeclampsia. So looking at our differential diagnosis then, when women come in, at some time after 20 weeks with hypertension, how do we decide what the diagnosis is? Well, chronic hypertension should exist prior to pregnancy, or at least prior to 20 weeks gestation. It can also be defined as hypertension that is first seen after 20 weeks, but persists for more than 12 weeks postpartum. And, I think most listeners will pick up on the fact that that makes it a retrospective diagnosis, and that is absolutely true. Now, superimposed preeclampsia is, of course, new proteinuria in a patient with chronic hypertension or a sudden change in their clinical presentation with an increase in protein, blood pressure, or other findings. Gestational hypertension is primarily diagnosed as being not preeclampsia, so it shares the diagnosis of hypertension, and it can certainly be associated with adverse outcomes as well, but is less classically associated with proteinuria and doesn't have evidence of end organ dysfunction. HELP syndrome is, one of the dreaded complications of preeclampsia or types of preeclampsia. Again, hemolysis, elevated liver function tests, and low platelets, which can lead to liver rupture and has a high association with eclamptic seizures. 80% of women will present with right upper quadrant or epigastric pain. So in addition to this kind of hodgepodge of different types of hypertension diagnoses, women who come in with new hypertension or proteinuria in the later second or third trimester of pregnancy can also have one of these other problems. They could have an exacerbation of their pre-existing renal disease, perhaps an lupus flare, antiphospholipid syndrome, acute fatty liver of pregnancy, TTP or HUS, or mirror syndrome. Mirror syndrome is a unique obstetric complication, which is a case in which moms mirror the fetal condition. So babies have hydrops, they have fluid collecting in their various different cavities, and somehow this then triggers edema also in mom, which results in these higher blood pressures and preeclampsia. 80% of preeclampsia occurs at term or post-term, and 20% preterm, so under 37 weeks. Preeclampsia has been reported out as long as 3 weeks postpartum. But if hypertension appears later than that, a comprehensive evaluation for other sources should be undertaken. Who gets preeclampsia? Well, the highest relative risks are in those women who have prior preeclampsia or who have underlying chronic hypertension. But basically anything that makes you anything other than a woman who is under 35 with a normal BMI and healthy is likely to have some increase in your risk of preeclampsia. So twin or triplet pregnancy, chronic kidney disease, autoimmune disease, notably lupus, a high BMI, women who are having their first pregnancy as opposed to second or third, and women with a family history of preeclampsia. Preeclampsia can be a pretty dangerous disease in the short term. Women are at risk of liver rupture, pancreatitis, posterior reversible leukencephalopathy syndrome, cortical blindness, which thankfully is usually transient, and stroke, most hemorrhagic. Babies, unfortunately, are at risk as well. Certainly, most commonly, they present with growth restriction. Babies are more likely to be born preterm, either due to growth restriction and non-reassuring fetal assessment or because of maternal complications necessitating delivery. Either way, they can end up with the long-term complications of prematurity. Stillbirth is also well associated with preeclampsia. So how do we manage preeclampsia? Well, that's largely dependent on how far along mom is in her pregnancy and how bad the preeclampsia is. So in those women who have preeclampsia with severe features, we still try to keep them pregnant for at least 34 weeks. After 34 weeks gestation, if a mom presents with clear preeclampsia with severe features, we typically recommend moving to delivery because delivery will minimize both maternal and fetal complications with few long-term consequences of preterm birth. In addition, and this is very difficult counseling, if women present with pre-viable preeclampsia, so for example, at 22 weeks, we often also counsel towards delivery because preeclampsia at this gestational age tends to be fairly fulminant and quite dangerous to mothers. If moms are less than 34 weeks and we think we can try to keep them pregnant, we start by giving them steroids, we control their blood pressure, and we monitor their babies closely. Preeclampsia preterm with severe features is an indication for inpatient observation, whether it be for weeks or months. Again, hoping to avoid those complications of extreme prematurity while keeping moms safe. If moms are, I guess, lucky enough to develop their preeclampsia at term or after 37 weeks, we then recommend delivery regardless of the severity of their disease. In the Habitat trial, now no longer brand new news, women had a 30% decrease in maternal morbidity and mortality if they were induced with presentation of hypertension. They had a decreased cesarean rate and no difference in the neonatal outcomes. Women with an unfavorable cervix should still be induced. Inductions are less costly than expectant management due to the needs for example, hospitalization and intensive testing. We have lots of options to control blood pressure during the pregnancy. Many, many different medications can be used safely during pregnancy. In the setting of acute hypertension, though, these are the three that we tend to lean on: hydralazine, labetalol, and nifedipine immediate release. These are used most safely under a clinical protocol, and many protocols exist for utilization of these medications. So why do women develop preeclampsia? Well, we don't really know. We have some thoughts. We do lack the ability to predict which women will develop preeclampsia, but I am hopeful that in our lifetime that will change. There are limited preventive and therapeutic options, and delivery remains the primary intervention. Much work has been done on the pathophysiology of preeclampsia. And there has been the observation that shallow placentation and failure of spiral artery remodeling occurs early on in the pregnancy, such that our research scientists are able to demonstrate changes in the placental secretion of anti-angiogenic factors like sFlt1, decreased placental growth factor, resulting in maternal vascular dysfunction. Many histologic changes have been identified in the placenta with villus and vascular lesions, acute atherosis, placental infarcts, villus hypoplasia. And similarly, histologic findings have been demonstrated in the kidney of glomeruloendotheliosis. All in all, though, preeclampsia remains one of the most common causes of maternal death around the globe. Preeclampsia, or hypertensive disorders of pregnancy, result in 15% of maternal deaths around the globe and nearly 6% of maternal deaths in the United States. These deaths are not equally distributed across populations, and most have probably heard that Black and Indigenous women are at highest risk of maternal death, many of these deaths related to hypertensive disorders of pregnancy. So we've been talking about preeclampsia and some of the severe complications of preeclampsia. Let's talk a little bit about eclampsia as well. So as I alluded, preeclampsia and eclampsia are diseases of the placenta, and they're diseases that have been around as long as pregnancy has. Eclampsia, the association of seizures with pregnancy, was first described more than 5,000 years ago in the Egyptian papyri, and similarly in the ancient Chinese literature as well. Hippocrates wrote of the association of headache, seizure, and pregnancy in 400 BCE, but Boissier du Sauvage in the 1700s was the first to use the term eclampsia, which is a Greek term meaning lightning, demonstrating the rapid onset of the seizures that occur with pregnancy. Eclampsia is an old disease, and we use an old medication to try to prevent it as well. We use a very old-fashioned medication, which is magnesium. Intramuscular magnesium was actually introduced in the 1900s, and the 1920s brought along the intravenous injection. And thankfully, the 1990s brought randomized controlled trials. So magnesium in large studies was demonstrated to be more effective and safer for prevention of recurrent seizures than phenytoin or diazepam. We use magnesium in a couple ways. It can be given as a 6-gram bolus and 2 gram per hour infusion, which is given during the labor course or intrapartum, and then for 12 to 24 hours postpartum as well. It can also be given as a 4-gram bolus, 1 gram continuous, and it can also be given as a 5-gram intramuscular injection into the buttocks for women without IV access. Magnesium is renally cleared and can quickly reach toxic levels in women with renal insufficiency, in which case we frequently will just give either one loading dose without an infusion. We may check levels looking for our therapeutic range. The number needed to treat for women with preeclampsia with severe features in order to prevent one seizure is 60. The antidote for magnesium toxicity is 10% calcium gluconate given IV. Eclampsia, unfortunately, impacts between 1 in 2,000 to 3,500 pregnancies. Some women, and not all, report symptoms prior to the eclamptic seizure. This is most commonly in about 60%, a persistent occipital or frontal headache. They can present with blurred vision, photophobia, epigastric or right upper quadrant pain, or altered mental status. Preeclampsia and eclampsia are diseases of the placenta, and the resolution occurs after delivery. The acute features often will resolve fairly quickly, such as headache, but others can take weeks or months. Proteinuria, hypertension can take some time to resolve. If you all remember from medical school, plasma volume increases by about 50% during pregnancy, and much of that is in the third space. Women tend to mobilize all of that fluid within 2 to 3 days after delivery, which frequently results in a rise in blood pressures. If they can't deal with all of that volume, sometimes they drop it into their lungs and develop pulmonary edema. So this can be a time that's fairly tenuous for moms. It's not necessarily an immediate recovery postpartum. How do we screen women for preeclampsia? Well, we look at their traditional risk factors, as we've discussed. So women having their first baby, older women, higher BMI, history of hypertension, diabetes, multiple gestation. We measure blood pressure at all visits during the pregnancy. We do a baseline assessment of proteinuria, and then we reevaluate for proteinuria for moms who are hypertensive. There are no biomarkers that are currently being used in clinical practice, although many certainly being developed in the lab. How do we prevent preeclampsia? Well, we don't have a lot in our toolbox, but at least we have something, and that something is low-dose aspirin. So one of the very few obstetric recommendations by the United States Preventive Health Task Force is for use of aspirin to prevent preeclampsia in women at moderate to high risk. Low-dose aspirin has an excellent safety profile. In the European studies, the low-dose aspirin is available at different doses than that in the United States. We have 81 milligrams available, and most providers will give 81 milligrams starting in the first trimester through the end of pregnancy. A 2019 meta-analysis, including more than 40,000 women published in the Cochrane database, demonstrated a relative risk of 0.82 for reduction in preeclampsia in treated women. So again, women, at least with one major or multiple minor risk factors, should be offered aspirin for preeclampsia prevention. What about after delivery? How can we help these women to optimize their health in the long term? Well, one thing we know is that women who develop hypertensive complications of pregnancy are at greater risk for developing cardiovascular disease later in their lifetime. And we don't think that development of preeclampsia is the trigger for the cardiovascular disease, but probably more so that women who develop preeclampsia are genetically predisposed towards developing hypertensive complications later in life. The morbidity is associated with the severity of disease, the gestational age of delivery, and how many disease recurrences they had. So how many times did they get preeclampsia in their pregnancies? This little table gives you a little bit more information. So women with a history of preeclampsia have increased lifelong risk of hypertension, relative risk of nearly 4, stroke, nearly 2, venous thrombotic event, nearly 2. So if you have a history of preeclampsia, your absolute risk when you're in your 50s of developing heart disease is 18%, as opposed to 8% if you had not had preeclampsia. And again, you know, that risk is much higher if you have preeclampsia with severe disease as compared to mild. So I always recommend to women who have had hypertensive complications of pregnancy that they connect with their primary care doctor within the first few months postpartum to really optimize their cardiovascular risk profile for the long term. So long-term complications, as we said, heart disease, hypertension, renal disease, and also type 2 diabetes. What are the barriers to research? Like, why haven't we solved this problem that's been around for as long as pregnancy has existed? Well, it seems that preeclampsia has a lot of different phenotypes. It's probably not just one disease. There's early disease that's fulminant versus this very mild, relapsing and remitting kind of hypertension that sometimes can occur at term. Disease can be mild or severe. Sometimes it's accompanied with fetal growth restriction, sometimes it isn't. Some women with HELLP syndrome, does a woman with HELLP syndrome at 26 weeks have the same disease as somebody who comes in with a little hypertension and proteinuria at 39 weeks? It's hard to know. There are genetic variables, there are environmental variables, differences in underlying maternal disease, fetal factors. So a lot of work to be done, and a lot of work is being done. In the last few minutes before we close, I just want to speak a little bit about breastfeeding. So it is very easy for women who have had complex pregnancies, or for women who, for example, are readmitted for postpartum complications, to either not ask for a pump, not be given a pump. They don't really feel up to breastfeeding. They feel tired, or they're being given medications for which there is some doubt as to whether they're safe in pregnancy. So breastfeeding sometimes in these circumstances is thought of as optional. There's an interesting hypothesis, which is called the reset hypothesis. And the idea behind it is that pregnancy is a time where a woman's body is changing and preparing to nurture the baby inside and also outside. So for example, we don't check lipids during pregnancy because they're always elevated. And the idea is that maybe breastfeeding is the switch that tells a woman, oh, you're not pregnant anymore. You can go back to the way your body was before pregnancy. And this is borne out by now many studies that were now starting to be published nearly 10 years ago, which demonstrate an increased risk of hypertension and diabetes during a woman's lifetime if she is pregnant and doesn't breastfeed. So what you see here on this slide is first some data from the Nurses' Health Study looking at nearly 90,000 women. And if you were never pregnant in this study, you were considered at the baseline with X risk of lifelong cardiovascular disease. If you were pregnant and never breastfed, you actually have an elevated lifelong risk of cardiovascular disease. If you breastfeed for 3 months postpartum, you'll be down below what your risk would have been if you had never been pregnant at all. And in fact, if you have a lifetime total of 2 years of breastfeeding, you have a 23% lifelong risk lower of developing cardiovascular disease. Similar findings were seen in the Nurses' Health Study 2, another 55,000 women, as well as other similar large population studies. Similar data also exists, I should say, for type 2 diabetes. So if in doubt, if you're talking about medication, please go to LactMed. So I use this website all the time. I pull it up at the computer while I'm sitting with a patient, and we review the medications that she's been advised that she might need to take postpartum. And we go through each one of them and we read what the breastfeeding information is. This is a free access website from the NIH. It's very, very readable, easy to use. And I think that you will be very pleasantly surprised at just how many medications are actually considered to be compatible with breastfeeding. Many women still are being advised to pump and dump, for example, also after radiologic studies. So pumping and dumping can really impact breastfeeding success and is generally unnecessary at this point. So I hope that you'll take those extra few minutes always to consider whether the work that you're doing to keep women healthy and safe can also be done in a way that is compatible with supporting and encouraging breastfeeding. So that is all I have, just an acknowledgement for some of the historic references. And thank you very much. I look forward to the panel discussion with questions.